I'm now going to do a focused examination on the eyes. This will include visual acuity, the visual fields, the extraocular muscle examination, as well as fundoscopic examination, and of course inspection of the visible structures of the eye. A systematic exam of the eyes can tell you a tremendous amount about neurologic function, and we'll talk a little bit about that as we go. So we always start with inspection. Move to the front of the patient, and we first of all just want to inspect for symmetry. We're looking particularly at palpebral fissures. You can notice that you can see sclera below the lower edge of the limbus. That's entirely normal, but the upper edge of the limbus or iris is covered by the upper lid, and that's normal as well. If we had visible sclera above the limbus, that would be called show. It can be normal in some people, but is definitely unusual. Also want to examine the sclera, so I'm going to have you just look a little to your right to expose the sclera, then to the left. Good. Look up and look down. Okay, look straight ahead. We'll examine the conjunctiva. Tilt your head forward a little bit. Look up. And we can look into the conjunctival sac, looking for any accumulation of debris, pus, mattering, foreign bodies, anything that you might see. It's very important to inspect the lid margins. Blepharitis or inflammation of the lid margins and the lashes are very common. You may see scaling in that area, redness, a mild amount of injection or redness in the conjunctiva on the bulbar surface of the conjunctiva as well. So you want to look in the areas of the lacrimal glands, which are right here under the orbital rim. If there's swelling in that area, it may indicate some involvement of the lacrimal glands. And then look at the tear flow. The tears flow across the eye and then are gathered at the inner puncta here, at the inner canthus of both eyes. Any tearing suggests that there may be some obstruction of the tear ducts and the nasolacrimal ducts that drain the tears into the nose. Next part of the exam is to examine the muscles of the eye. To do that, we want to isolate each group of muscles, and we do that by moving the eyes through the 6 cardinal points of vision, which are to the right, up and out, to the left, down and out, and down and out. That isolates the individual muscles. The other thing we will check at this point, look right at my finger, is convergence. And during convergence, you should see the pupil constrict. That's near point constriction of the pupil. Look right here again. And back out. Oftentimes mislabel accommodation. That is not accommodation, that's near point adjustment. Next, we'll see if there's any latent weakness of the eye muscles. You're always examining the axis of vision. A good way to pick up on that is to see where the light reflection is on the cornea. It should be absolutely symmetric between the two corneas, which is. We'll do the cover-uncover test. What this involves is covering one eye, having the patient look right at your nose, and then uncover. And what you're looking at the uncovered eye to see if it moves to take up fixation again. Now I'm going to cover the other eye, look right at my nose, and we'll look at the left eye as I uncover and see if it moves to take up fixation. And his may move actually very, very slightly. So normally the eyes are aligned along the axis of vision, whether you're actually seeing out of that eye at that point or not. If the eye has some muscle weakness, the eye will drift when it's not being used actively, and it will come back into alignment. So again, cover, uncover, cover, uncover. Okay, and he's normal. That's called atropia. If we see that, if the eye is lazy to the outside, it's exotropia. If it's lazy to the inside, it's an esotropia. There's another type of weakness called aphoria. This is just a latent weakness, and we can bring that out by what's called the alternate cover test, and this involves fairly rapidly covering one eye and then the other back and forth. And this will sometimes uncover a very latent weakness of one eye. So you look right here, and again, we're looking for any fixation movements of the eye. They should stay rock solid at the axis of vision, right here on my nose. Cover, cover. And he's perfectly normal. But that's a good test to pick up aphoria or a very mild weakness of the eyes. So we'll next move on to examine the pupillary size and reaction. This requires use of a fairly bright light. Look right here. It's important to remember that the pupils should be of the same size regardless of whether they have the same amount of light coming into them. The retina and brain together average the light exposure and adjust pupillary size, so it should be the same. Therefore, any difference in pupillary size or an anisocoria is abnormal. Some people have slight anisocoria at baseline, but an acquired anisocoria is abnormal. So the first thing we're going to do is just check reaction to light. The pupil constricts very nicely. Remember to give enough time for the pupil to readjust. You'll occasionally see a sort of bouncing of the pupil like this. That's called hippus, and that is normal. Next, we're going to check for a relative afferent pupillary defect, and we do that with a swinging light test where we're going to put the light in one eye and then the other, and then we're going to see that if the pupils respond both directly and consensually. So we'll start with the left eye. It constricts, and now it dilates. I'm still looking at the left eye with the light in the right eye, and the left pupil constricts as well. Now I'm going to go back and look at the right eye as the light goes in the left eye, and the right pupil constricts. And then I'm going to check the right eye directly, and it constricts. So what that tells me is regardless of which eye I shine the light in, both pupils constrict. If there's a relative afferent pupillary defect, the abnormal, when the light goes into the abnormal eye where the retinal signal is not as strong, then the pupils will not constrict the same as they do with the other eye, and that's a relative afferent pupillary defect, or RAPD. Next, we'll do the fundoscopic exam. Fundoscopy is a very important skill to acquire. It takes a lot of practice. The ophthalmoscope is always used in the right hand, your right eye to examine his right eye, and then opposite, your left hand, your left eye to examine his left eye. It's important to start at 0 diopters, and you start a good distance from the patient. Notice that again I'm gathering the cord to take tension off this so I don't have to grip hard. My thumb is on the light adjustment and my finger is on the diopter adjustment. Make sure that the light is centered on the eye, bring it up to your eye, and then you can look for the red reflex, which indicates that you're seeing the retina. And then focus in. And adjust to identify the optic disc, which is the key landmark. The arteries flow out of the optic disc both nasally, two nasally and two temporally. Look at the optic cup. Inspect for the size, the cup to disc ratio, the sharpness of the optic disc, and then you can follow the arteries and veins out into each quadrant looking for arteriovenous crossing changes, narrowing of the arteries, hemorrhage, exudates, etc. And last of all, you move just a bit to the temporal side and you can see the macula, which the patient doesn't appreciate because it's very, very bright. It's important to try to avoid the macula when you first look in. The way to do that and the way to identify the optic disc is to recognize that the optic disc sits a little bit on the nasal side and a little bit inferiorly. Therefore, and since I'm taller than him and I'm looking down both nasally and inferiorly, I should be able, with him looking virtually straight ahead, to come right in and hit the optic disc dead on, which I do. If he were taller than I, so his eye's here and his optic disc is here, I'm going to have him look down immediately, so when I look up, I'm finding the optic disc. So now we'll go over to the left eye. Once again, tension off the ophthalmoscope. Support the head from behind. And left eye, my left hand, his left eye. Look straight ahead. Get the red reflex, and then you move straight in. Identify the pale optic disc. And again, examine the edge of the disc and then the more peripheral fields. I won't go through that whole exam. Fundoscopic exam is really beautiful. It's one of the only places in the body you can actually see the capillary and arterial flow. And you can get a tremendous amount of information, and the ability to readily find the optic nerve head and evaluate for papilledema is very important in a wide variety of settings. So one should get very comfortable with doing it. Notice that I did that without darkening the room too much. You can certainly, with dilating the pupil or in a dark room, be able to see perhaps a little bit more. But I think you can do it quite well in this sort of low ambient lighting as well. We're going to check his visual acuity. This is oftentimes done and probably best done with a full Snellen chart at 20 feet. You can have your nurse do that before you ever see the patient. But you can also do a good job with the handheld chart. And we do this by putting this about 14 inches from the patient and having him read the smallest line that he can. And we'll have you cover your right eye and read the smallest line that you can. You can hold it if you may be easier.
859-40372.
Okay. And with the cover your left eye, once again, read the smallest.
859-40372.
Okay, so the same in both eyes. Now read it with both eyes.
859-40372.
Okay, so the eyes are each the same. And he's 20/20. So excellent normal vision. These cards are very useful to have. They allow you to check visual acuity. And they also give you a reference for pupillary size, and very nice to hold in your hand. So after checking the visual acuity, I want to say a few words about checking for visual fields. There are several different ways to do that. The most accurate way is color confrontation. Other good ways are hand or face confrontation and finger confrontation, which I'll show you those methods. Unfortunately, the method that's often taught, which I'll demonstrate with wiggling a finger in from the side, is the least accurate way to check for visual fields. So I'll demonstrate each of these. The most accurate way to check visual fields is with color confrontation. What the ophthalmologists use are the red heads of mydriatic bottles that they keep at the side of all the patients. You want to stand about 3 feet from the patient, and you're going to expose these in the visual fields First, with both eyes, remember we can check the temporal visual fields with both eyes open, but to assess the nasal visual fields, we need to test one eye at a time. So what we do is expose these briefly to the patient and ask them to tell me whether the two colors appear to them to be the same or different. So are you ready?
Mm-hmm.
Okay.
Same.
Okay.
Same.
Okay. So what that's telling me is that the temporal fields in right and left appear to be the same. Now I want you to cover your right eye, and we'll do this again. Again, we're going to check top to bottom. Same or different?
Same.
Okay. Same or different?
Same.
Okay. Same or different?
Same.
Same or different?
Same.
Okay. And reverse, check the next eye. And we'll do the same thing. Temporal fields,
Same.
nasal fields,
Same. Same.
quadrant to quadrant.
Same.
Okay. So color confrontation is the most accurate way to check for visual field cuts. Interestingly, visual field loss is often not noted by the patient. People can have profound visual field loss and not notice it at all. This would be equivalent to you and I not noticing that we don't notice what's behind us. So you really don't notice what you don't see. You just assume the world is what you see. So it's very important to check visual fields. In fact, if you only do one test of the eye, that's probably the most important. A couple other ways to check visual fields. So there's hand confrontation. So I want you to look at my hands. Do they look the same or different? Any blurry or fuzziness difference between the two?
Same.
Okay. Another way is to look at my face. Right here at my face, any blurry or fuzziness from one side to the other. Okay, cover your right eye. Again, hands,
Same.
hands.
Same.
Okay, look right at my face, right here in the middle. Any difference in the perception of my face?
Nope.
Okay, so if there were a visual field cut with one eye and he looks at me, one side of my face might look a little bit blurry, not as distinct as the other. Let's do it on the other eye. So look right at my face. Any asymmetry? When he's doing that, you need to be sure he's looking right at your midline so that you're separating the visual fields. And then hand confrontation.
Same.
Hands,
Same.
hands.
Same.
Okay. And then last, the one that I use most commonly in the office is finger confrontation. This involves asking the patient to sum the total number of fingers that you hold up. And again, you should use 1, 2, or 5 fingers. I usually just use 1 or 2. It's very hard for people to distinguish 3 and 4 fingers, so that is too confusing. So what we'll do is, again, start with the temporal fields, and I have you look right here at my eye, or my nose. Total number of fingers.
4.
Total number of fingers. Okay, cover your right eye. Total number of fingers. Total number of fingers.
4.
Okay, very good. I was a little quick on that one. Okay, cover your right eye again. Okay. Total number of fingers.
3.
Okay, total number of fingers.
4.
Okay, cover your left eye. Temporal fields.
4.
Okay. Nasal fields.
2.
Okay.
2. 4.
Okay. So we've checked all 4 quadrants. We've checked temporal and nasal fields, and that's a very quick way to check. Remember, make sure that you're looking at his eyes. Make sure that you're displaying the fingers halfway between you and him, and that you can actually see them as well, so that you're not putting them outside of his normal visual field. The way that visual fields are often checked, and I discourage this, is with the wiggling finger test. And this is done by having the patient look right at your nose, trying to start outside his vision and have him tell you when you see the wiggling finger. Okay? I will sometimes do this with a Q-tip. Allows me to get a little bit farther out. Look right here. Tell me when you see it. Tell me when you see it. And again, tell me when you see it. It's very hard to get far enough out to get out of their visual field. This is really not a very accurate way to do it. I strongly suggest people use one of the other methods. The finger confrontation is easy, fast, requires no equipment, and that's the one that I would suggest people use. So, visual field testing, extremely important. And once again, it's important to recognize people may have profound visual field deficits and be completely unaware of it. Very important part of your examination.